Un cordial saludo tengan todos desde la Organización Panamericana de la Salud. Ya en nuestros webinars tenemos que decir buenos días, buenas tardes, buenas noches, porque se vinculan muchas personas de diferentes partes del mundo. Entonces, mi nombre es Pedro Ordúñez, soy asesor regional para enfermedades crónicas no transmisibles aquí en la OPS y encargado de la iniciativa HARTS, que presenta su nuevo webinar en el día de hoy. Quiero decirle que en primer lugar me gustaría saludar a nuestra comunidad de países HARTS, que como ustedes saben son 12 países HART implementando la iniciativa. Solamente por recordar nuestros primeros países, tenemos 12 países, los primeros 4 fueron Barbados, Cuba, Colombia y Chile, y el segundo grupo de países incluyó Ecuador, Argentina, República Dominicana y Trinidad y Tobago, y tenemos también a Santa Lucía, también tenemos, quisiera asegurarme primero, discúlpenme un minuto, quiero pasar la palabra primero a Jenny Rodríguez, que nos tienes que dar algunas instrucciones en lo que vamos recibiendo los nuevos invitados. Adelante, Jenny, por favor.
Sí, buenos días. Vamos a dar inicio al seminario virtual sobre la enfermedad cardiovascular, hipertensión y COVID-19. La interrelación y oportunidades de cambio de dos crisis globales. Gracias a todos por su asistencia y puntualidad. Algunos aspectos técnicos importantes que tenemos que tener presente para esta sesión es que hay disponible la interpretación simultánea en español e inglés. En esta plataforma Zoom encontrarán la función de interpretación en la barra de herramientas inferior a la derecha, que se activa cuando mueven el cursor sobre la barra. Verán la opción Interpretación. Puede hacer clic en esta opción y seleccionar su idioma. Además, si prefiere no escuchar de fondo el idioma del presentador, haga clic en Mute Original Audio. Para los participantes que están siguiendo esta reunión, si tienen preguntas para los panelistas, por favor utilice la opción de Q&A o Q&A ubicada en la barra de herramientas en la parte inferior de la pantalla de Zoom. Para los panelistas, por favor mantener sus micrófonos apagados durante otras intervenciones. Si por alguna razón usted lo olvida, el host de la reunión lo puede desactivar por usted. Vamos a comenzar con las presentaciones de acuerdo con la agenda prevista y le doy la palabra al doctor Pedro Ordúñez, asesor regional de enfermedades crónicas no transmisibles de la OPS-OMS en Washington, D.C. Adelante, doctor.
Gracias, Jenny, gracias. Ahora sí. Yo estaba diciendo que este primer momento de inicio del webinar de HART siempre, yo digo que este es el momento más emocionante, ¿no? Cuando usted abre la sala de Zoom y empiezan a correr los participantes, ahora mismo hemos comenzado con 245 participantes, sigue creciendo el número y yo quería en primer lugar, además de saludarles a ustedes de la Organización Panamericana de la Salud, aprovechar que ustedes están conectados y si ustedes conocen personas que todavía no se han conectado, por favor, pásenle un mail, pásenle un texto diciéndole estamos en vivo, estamos comenzando la presentación de este webinar que en el día de hoy estará dedicado a un tema que es esencial en estos días. Se llama enfermedad cardiovascular y COVID-19. La interrelación entre dos crisis globales, la crisis de enfermedades cardiovasculares y la crisis de COVID-19. Estamos buscando identificar las oportunidades que nos ofrece para el cambio que nos ofrece este momento tan complicado, tan dramático, tan importante que estamos sufriendo todos. Mi primer pensamiento, como siempre, para los que han perdido un familiar, un amigo o un ser querido durante estos terribles meses de pandemia de COVID-19. También quisiera recordar a todos los que han sido afectados por esta pandemia, que de una manera o de otra han sido afectados en muchos lugares del mundo. Y claro que el dramatismo y la gravedad de esta pandemia nos hace que, de nuevo, estemos insistiendo en que este sea un tema muy importante. Y por supuesto, siempre recordamos a nuestros colegas que están en la línea de frente atendiendo a los pacientes graves, pero también los que están en la comunidad asegurando los cuidados a los que requieren cuidados cardiovasculares y cuidados de salud en general. Este webinar en el día de hoy va a tener, como siempre, un roster de participantes y de ponentes de primer nivel. Yo quisiera recordarles solamente el programa que vamos a presentar en el día de hoy. Bueno, en primer lugar, vamos a tener una sesión dedicada a enfermedad cardiovascular y COVID-19, la interrelación y los enfoques que pueden ser comunes a estas dos condiciones. Y para esto vamos a tener un panel de lujo que va a estar integrado por, en primer lugar, nuestro querido profesor Donald De Petty, que todos lo conocemos muy bien porque Donald ha sido clave ayudando a los países de nuestra región a tener protocolos de tratamiento que funcionen, que sean prácticos y que sean basados en evidencia. También vamos a contar en el día de hoy con la presencia del profesor Daniel Glagland, es otro de nuestros asesores, fue pasado presidente de la Liga Mundial de Hipertensión y es un ferviente creyente de que tenemos que avanzar con el tema de las enfermedades cardiovasculares. El otro colega que vamos a tener en el día de hoy, también asesor de HART y que va a tratar el tema de innovación en cuidados cardiovasculares, es el profesor Kenneth Conner, que viene de Barbados y es uno de nuestros asesores también de CIA. Y vamos a tener ese primer panel que nos va a estar presentando ahora mismo cuáles son las características de esta interrelación entre enfermedad cardiovascular y los enfoques que son comunes para enfrentar el COVID-19 y la enfermedad cardiovascular. En un segundo momento vamos a tener un journal club, un club de revistas, como se dice también, para anunciar un grupo de publicaciones que son muy recientes, ¿no verdad? Y que yo voy a dejar esto en la sorpresa, pero tenemos dos publicaciones que se acaban de publicar en revistas arbitradas y también tenemos una publicación de la OPS. El primer módulo de publicaciones va a tener un comentario del doctor Yamario Esquite, que Yamario también está colaborando con nosotros, es uno de los iniciadores de HART en Barbados. Ahora está haciendo su residencia también en cardiología. Y bueno, Yamario va a ser un punto importante para comentar qué implicaciones tienen estas publicaciones. Y vamos a también tener a nuestro colega de la OPS, el doctor Ludovic Rebey, que va a presentar un comentario sobre la última publicación de la OPS relacionado con una evaluación de las intervenciones terapéuticas para COVID-19. Entonces, sin más preámbulo, quisiera presentar de inmediato de nuevo al profesor Donald De Petty, que es profesor distinguido de Ciencias de la Salud de la Universidad de Carolina del Sur y también de la Escuela de Medicina de Carolina del Sur en Columbia, en Carolina del Sur, los Estados Unidos. Así que bienvenido, profesor De Petty, el micrófono es suyo y adelante a disfrutar de la presentación. Y los demás a pasar la voz, el webinar está en vivo ahora mismo, pasen la voz, tenemos 300 participantes. Adelante, profesor De Petty. Profesor De Petty.
He has to unmute his microphone.
Okay.
There we go.
Okay, great, excellent.
Okay. Can everybody hear me? Pedro, can you? Pedro, thank you very much for that kind introduction. It was too generous. It's an honor and a pleasure for me to give the overview. To really, the goal of this presentation is to try to, do a synopsis of why we're here, where we're going, and obviously to put the webinar together. Gloria, next slide, please. This slide really, I think, is important to tell us why we're here today and why this webinar is so important. And that is the tremendous and deleterious interrelationship between what I'm going to call the acute COVID-19 pandemic and the chronic non-communicable disease pandemic. And when you put these two together, it really is a perfect storm of morbidity, mortality, and of course, devastation, not only in disease, of course, and family burden and personal burden, but economic burden and hardship. Let's start with the acute COVID pandemic on the top of the slide. This, unfortunately, as we're going to see in much more detail, has led to an interruption of NCD management. And wherever, for the purposes today, we see NCD management, you could put hypertension or any disease that you wish in the NCD community on to this slide. The interruption of services has led to increasing the chronic NCD pandemic, which unfortunately leads to increasing the morbidity and mortality of NCDs. That would be bad enough if that didn't increase the comorbid diseases with COVID-19, leading to increased COVID-19 morbidity and mortality and further worsening the acute COVID pandemic. That is why we're here this morning or wherever the participants are during the day. Next slide. Well, again, why hypertension? Well, number one, as again, we're going to see in much more detail, hypertension is a major, if not the leading comorbid risk factor for COVID-19. But also we all know, and we're here today because we know that the control rates of hypertension in low, middle, and as you're going to see, even high income countries is really, really pathetic, if you will, and needs continuous improvement. Next slide. I know most of us are discussing low and middle income countries, but I just want to share with you this recent publication from the United States. The NHANES data, which is our US population-based data, has really sounded an alarm and a call for action. Through the decades of increasing hypertension control, we were doing reasonably well, as recently as about 50 to 60% control rates. Unfortunately, something has dramatically changed. In the last report in 2017 and 2018, we've now seen a significant and sudden decrease in hypertension control rates to the low 40%. If we apply the newer ACC-AHA criteria, the control rate, again, in the United States would be as low as 19%. This also parallels the recent increase in CVD-related morbidity and mortality. And that is the call to action. That has sounded the alarm. Again, even in high-income countries. Next slide. This led to just this month, the United States Surgeon General's call to action to control hypertension report. This report has 3 overall goals. Goal number 1 is to make hypertension control a national priority. Goal number 2 is to disseminate the importance of hypertension where people live, learn, work, and play to increase the control rate of hypertension. And really pertinent to this webinar, the third goal is to optimize patient care for hypertension control. And the very first strategy of this goal, strategy A, was to advance the use of standardized treatment approaches and guideline recommended care, including, as we're going to discuss, hypertension formularies and treatment protocols or algorithms. Next slide. So it appears that what we've been doing has worked somewhat and now has even leveled off and or decreasing hypertension control rates. And I think that probably calls for a different approach. We started when there was no pharmacologic management for hypertension or even the knowledge that hypertension should be treated with no care. That quickly, when pharmacologic agents became available, morphed to step care approach. That then gave way to individualized care where most of us are living today. And I believe now the call is to move to a population-based care approach as we're going to discuss. Next slide. Well, there are many elements in a overall population-based or public health care, primary care, if you will, to the delivery of care to increase hypertension control. But even more important is the implications in the COVID-19 pandemic. And I highlighted the one that we're going to be addressing this morning, and that is medications. This is what I'm going to be talking about, which is standardized, broadly available, integrated into small, comprehensive formularies, and present a straightforward treatment approach in the form of a protocol or an algorithm. Next slide. There are many barriers to hypertension control. However, a standardized formulary and treatment protocol does attack some of these barriers very specifically, such as a patient barrier of poor adherence to treatment, a healthcare provider barrier or barriers of therapeutic inertia, and lack of adherence to treatment guidelines, even though treatment guidelines are available, and health system barriers such as relationships to supply or distribution and cost, as well as the complex medical regimens that exist today. Next slide. Well, there are three classes that we can choose from by most, if not all now, hypertension guidelines: the diuretics, the renin-angiotensin system inhibitors such as ACE inhibitors and ARBs, and the calcium channel blockers. Next slide. I leave beta blockers in here with just the reminder that they should be left as for compelling other indications of the individual patient's care, not for the primary treatment of hypertension. Next slide. Well, what are the ideal characteristics of an individual medication if we were going to choose one? And they are summarized in this slide. Of course, they have to be safe and efficacious and well tolerated. They have to be supported by evidence base, as Dr. Adunis has already mentioned, and they have to be affordable, and more importantly, they have to be available. It would be very nice if ideally they had daily dosing for adherence and ease, and also if they came in a scored tablet, which might then permit pill splitting. Next slide. However, I think we are now moving beyond the individual initial treatment of hypertension with a single agent. That would be the individualized treatment, if you will, to now looking at the advantages of initial combination pharmacologic therapy. And there are many advantages seen in this slide. The most important of which is, if we start with the end in mind, which is increasing hypertension control, most individuals, even in the primary care setting, will need 2 or more antihypertensive agents. So why not start with more than one initially? There's greater efficacy, which will improve blood pressure control. You use less doses of 2 medications, so you would reduce side effects. It's a simplified treatment regimen for better adherence. It reduces clinical inertia. And when complementary classes of agents are chosen, and I think this is a really important advantage, especially when we're talking about geographic, regional, and global hypertension control. When you use 2 complementary classes together, you lower blood pressure equally across very diverse demographic groups. And of course, there may be economic benefits long-term, despite the initial increase short-term for pharmacologic costs. Next slide. Well, that in mind, if we're going to start with 2 medications, what are the ideal characteristics of combination medications that we could choose? And again, they're very similar to the same ideal characteristics of the individual agents themselves with a significant expansion. Number 1, again, they must be highly efficacious. They must have adequate additive or synergistic blood pressure reduction. Again, evidence-based. They should mitigate each other's side effects. That would be ideal. And we know that there are certain combinations that do that. They have to have the potential for wide availability and affordability. Again, safe and effective across diverse demographic settings. And again, daily dosing, and perhaps even in a scored tablet, if you will. Next slide. So with that in mind, which 2 classes? A group of us convened again by Dr. Adunis and Pajo published this paper in the JCH, which recommended 2 classes of agents. The preferred 2 classes was a renin-angiotensin inhibitor in combination with a calcium channel blocker. Acceptable combinations would be the RAS inhibitor, either an angiotensin receptor blocker or angiotensin converting enzyme inhibitor with a thiazide or thiazide-like diuretic. We chose at the time to list a CCB and diuretic combination as not preferred, predominantly because of less evidence-based medicine. Next slide. So once that has been chosen, what is the process? Select a preferred and acceptable pharmacologic drug class. Select preferred and acceptable pharmacologic agents within each class. and then select which preferred and acceptable combinations are available and affordable. Next slide. And this can be done in a staged approach, as Dr. Skeeth is going to more fully review the paper which this comes from. Clearly start with the end in mind. There must be a current protocol that it could be immediately put in place. Even at the same time, we can be moving towards an acceptable protocol, and then perhaps even the preferred protocol, again, even if that's 12 or 18 months down the road. We have to start today. Next slide. So in summary, a standardized formulary and pharmacologic treatment protocol is more important than ever in the COVID-19 pandemic. We must use a standardized and simplified approach to hypertension control. We must use a small and specific medication formulary that is primary care based. Also, that formulary should be put into a straightforward pharmacologic treatment protocol that uses half maximal doses of 2 medications initially, better yet, even in a fixed dose or single pill combination. And finally, we can take a stepwise approach to protocol development. We can have a present protocol while we're aspiring to have an acceptable protocol, and then, of course, ultimately a preferred protocol if needed. Next slide. Thank you very, very much, Dr. Adunas, for having me, and I hope this presents an overview, and I look forward to the more specific presentations and the review of the Journal Club manuscripts.
Excelente, excelente. Yo creo que ha sido excelente comenzar de esta manera porque da una idea general por dónde vamos, por qué cosas importantes. Y yo le estoy diciendo al profesor De Petty, esté listo porque tenemos preguntas para usted con seguridad. Esto de que el enfoque individual versus el enfoque de salud pública, el enfoque de servicio de salud, sabes que eso crea algún ruido en los clínicos, ¿no? Y entonces tenemos, ¿cómo le vamos a decir ese tema? Así que prepárese ahí que vamos a tener buenas preguntas para usted en el intermedio. Yo quería seguir ahora y, bueno, decirle, bueno, he estado contando ahorita cuáles eran los países que tenemos, ¿no? ¿Verdad? Tenemos 12 países implementando este modelo, que incluye este protocolo estandarizado que estaba hablando el profesor De Petty hace unos minutos. Y quiero dar la buena noticia también de que estamos en nuestra cuarta corte de países HARDS, cuarta corte de países HARDS, y estamos recibiendo hoy, dando la bienvenida a este webinar a nuestros colegas de Bolivia que se han incorporado oficialmente, también a nuestros colegas de las Islas Vírgenes Británicas que se han incorporado oficialmente, y tengo que darle también la bienvenida a nuestros colegas de Porto Alegre en Brasil. O sea, tenemos 3 países más en HARDS, así que ahora somos 16 y hay 2 países más que se están preparando y esperamos que muy pronto estén con nosotros. Pero la buena cosa antes de pasar a la próxima presentación es que también en este webinar estamos teniendo participantes de Paraguay, Uruguay, Venezuela y Costa Rica que no están todavía implementando este modelo en sus países, de manera que seguramente que ellos tendrán muchas preguntas. Sin más, entonces quiero presentar nuestra segunda charla del día de hoy, que es enfermedad cardiovascular, enfermedad cerebrovascular e hipertensión en la época del COVID-19, y para eso yo tengo el placer de presentar al profesor Daniel Lagland. Daniel viene de la División de Neurociencias y Estudios Poblacionales del Departamento de Neurología desde la Universidad Médica de Carolina del Sur en Charleston, en los Estados Unidos. Así que, profesor Danny Glam, es un privilegio para mí presentarlo a la audiencia de HART, que ahora mismo nos están escuchando 400 personas, nos han estado escuchando en este momento. Adelante, profesor Daniel.
Wonderful. Thank you, Pedro. And thank you. It's so wonderful to be here with a lot of very, very good friends and certainly colleagues from all throughout the world. I want to talk a little bit about where we are with stroke, hypertension, et cetera, very similar to what Professor De Petty was bringing forward. As we look and think of the COVID-19, this is a slide that I think is very important as we consider our direction. And as you can see, beginning when we began the pandemic and seeing it affecting the groups in this particular case in the U.S. and directions, you started to see the deaths coming from COVID-19, these excess deaths that we see throughout, and then they're coming down, perhaps another plateau looking at the deaths. This is important because what you're seeing is that the COVID deaths are not replacing our traditional deaths from heart disease, from stroke, from kidney disease, hypertension related diseases. Those are remaining the same, and our group is still dying of folks that were almost at the similar type of conditions. We're still seeing that throughout the time. So we're not doing, what we're just seeing is a little bit of extra that we're seeing that's coming from the COVID-19. Another piece of that is that most of the deaths that we still have in our populations are still coming from those traditional reasons for death, and that's heart disease, hypertension related conditions. So it's not going away, it's staying with us, and we can't take a pause and totally divert ourselves to the COVID-19 without recognizing that the hypertension related conditions still are causing us problems. This is just a map you've seen quite often, that not only do we see conditions in this particular case looking at stroke as a leading cause of death throughout the world, we begin to also see that in certain parts of the world, stroke is the leading cause of death, and all throughout. And this diversity is so very, very important. If we look and focus at the Western Hemisphere, we see that, again, stroke in many places turns out to be it certainly is a leading cause of death. In many places, it is the leading cause of death and disability, a hypertension-related condition. Looking considerably more and bringing in these hypertension-related parts throughout the world, 2 points to make. As we begin to see stroke, ischemic heart disease are leading the way all throughout the world as main causes, hypertension-related conditions all throughout the world, leading reasons for disability, cost, and certainly morbidity. As we see this, the other point to make is that we see a tremendous amount of diversity. We see changes where some groups, while stroke and hypertension-related conditions are major problems, they do vary by country as to how severe and how much of a part that this is going to be. If we look just one more situation and thinking about the contribution that we see very, very similar, we see this in men and in women. So we're not looking at a gender specific or a gender greater risk, less risk, nor are we seeing with regards to race and ethnicity. Stroke affects many, many people, and it affects people and brings it through. Hypertension related conditions affect many, many portions of the population. I want to focus just for a moment on the United States and looking at stroke and stroke mortality, where we see that global effect throughout, where we're seeing diversity and carrying through. We see the same thing in the United States. And in particular, this has been a pattern that we've seen throughout, where stroke disproportionately affects individuals that live in the South, and in particular the southeastern portion of the United States, where Professor DePetty and I live here as our state. Many have referred to this as the stroke belt, the hypertension belt, if you will, with states like South Carolina, Georgia being what people will refer to as the heart of the stroke belt. The point is that we see this diversity, that we see portions of our population all throughout the world affected differently by hypertension and by hypertension-related conditions. Well, I would like to share some results of a report that we've just brought through very, very recently, a paper published in Circulation that has shown the things that Dr. DePetty was referring to, that where we can we do something? So here is a plan with hearts. Can we do it? Let's share what happened in the South, where we had the greatest risk of hypertension, where many people said, you can't do anything. This population is at great risk, and they're at great risk at a different time. So we focused in on blood pressure distributions from 1960 to 2005, at a time when we had the stroke belt, where people were dying of very, very strong and elevated blood pressures that were way out. In fact, 10% of the population in 1960 in the South had systolic blood pressures greater than 200. 10%. Well, what we show here is that for both whites and for blacks, the distribution of blood pressures has shifted to the left. It's shifted in all segments of the population and in all percentiles. So certainly those individuals with the elevated blood pressures that we would see that deserve treatment, you saw a shift to the left, no doubt due to good pharmacological therapy. But as another piece of hearts and another piece of the part, those individuals that are not quite ready for therapy yet, but are also ready for lifestyle modification. We showed a shift in the blood pressures for those individuals as well during this 45-year period. So a shift to the left in all segments of the population, in all groups in our population, and also we showed it for all percentiles of blood pressure. So it's showing that the components of hearts can indeed work, and it's based on evidence. And here is some evidence in a very, very high-risk population. From this paper, I did want to share one more piece that kind of emphasizes this point. And this is looking at the blood pressures. Notice that all age groups, you saw a significant reduction in systolic blood pressure in all age groups, for whites as well as for blacks. All age groups, a very, very significant reduction in elevated blood pressure came forward. So we know it works. It works in all segments of the population, the very high risk, the less risk, and all age groups, both genders, and all ethnic and racial groups. So let's summarize briefly what we do know. We know that the highest mortality attributed to cardiovascular disease typically have been seen in Eastern Europe and Central Asia. We know that the cardiovascular prevalence was high in the United States, Central Europe, North America, and the Middle East, bringing that forward. We also know that the overall, in 2017, the stroke prevalence, again, was highest. Again, looking at that that geographic diversity, where we're seeing different groups experiencing higher rates, but everybody experiencing disadvantages from elevated blood pressure. And then the top of those, thinking about hemorrhagic strokes, seeing those in those populations with the very highest levels of blood pressure. What we also showed was that between 1990 and 2015, that the number of deaths related to hypertension did not increase in high income countries, but did increase in high middle income countries. So we're seeing that the deaths, again, going back in here, bringing up for us a very important need in all portions of the country, that we need to address these excess risks, and we need to address them very, very quickly, that we can start to lower. And now you have a plan that could actually do this. And again, based on our data, there's almost 3.5 billion adults worldwide with systolic blood pressures between 110 and 115 and higher. And of this group, 874 million had systolic blood pressures greater than 140. So the population is here. Indeed, we know that we need to do something about it, and this is our call. And now we have something that maybe can do and make that factor. The clinical implications, finally, that we do have. The clinical strategies for high blood pressure detection, very important, measuring blood pressure, treatment and control, implemented in the latter part of the last century, again, is effective in all individuals. We know that the primordial and primary prevention activities that we also implemented in the clinical setting can have significant impact on blood pressure levels. And we also know that the early detection of hypertension using proper blood pressure measurement and prompt appropriate treatment can be effective in the high blood pressure control for all patients, regardless of population and social determinants. I think a very important thing, we have it right now. I'm so pleased to be a part and to support this effort to implement HARDS. Thank you.
Excelente, excelente. ¿Me están escuchando, por favor?
Sí, adelante.
Sí, es que se me perdió mi pantalla, discúlpame. Excelente, profesor Langland, por esta esclarecedora presentación. Yo llamo la atención, prestemos atención con mucho cuidado, vayamos escribiendo las preguntas, nuestro equipo está listo para recibir las preguntas que ustedes tienen, para que luego de la presentación siguiente hagamos una pausa y podamos ir a nuestras preguntas y respuestas. Llamo la atención que hay preguntas, muchas preguntas acumuladas. Vamos a tratar de responder algunas a través del chat. Vamos a tratar de responder algunas directamente a través de nuestros panelistas, pero quisiera llamar la atención de que este es un tema absolutamente relevante, ¿no? ¿Verdad? El mundo nos ha puesto entre un apuro con esto del tema del COVID, que venía a agravar la situación que ya teníamos del tema de las enfermedades cardiovasculares, ¿no? ¿Verdad? La hipertensión tiene unas prevalencias enormes en casi todos los sitios del mundo, ¿no? ¿Verdad? Como había dicho el profesor Landa, afecta a todas las poblaciones, todos los grupos de población, es un fenómeno tremendamente grave y el COVID ha encontrado allí un caldo de cultivo enorme para afectarnos más. Ahora, está claro que para responder a este enorme desafío, posiblemente tenemos que buscar innovaciones, tenemos que actuar de una manera diferente. Caso contrario, no vamos a poder reconstruir mejor si no empezamos a cambiar nuestra manera de ver las cosas. Entonces, por esa razón, yo he invitado hoy al profesor Kenneth Connell, que viene de Barbados, y que él nos va a comentar, nos va a ilustrar y nos va a llamar la atención sobre innovaciones en cuidados cardiovasculares e hipertensión arterial y qué lecciones estamos aprendiendo del COVID-19 que nos pueden servir para regresar mejor y reconstruir mejor nuestro servicio de salud. Adelante, profesor Kenneth Connell, es un placer presentarlo en el día de hoy. Adelante.
So thank you so much, Pedro, for your kind introduction. I was going to try to share my video, but I think I need permission from the host. And good morning, good afternoon from a very overcast and wet Barbados. The weather forecast today was actually meant to be bright and sunny, but this is 2020. And so nothing is surprising me during the year. I think this is a very relevant conversation because COVID-19 has disrupted the health landscape. It has disrupted our lives. And the one thing that might be beneficial coming out of all of this is that we kind of build back better, which is what WHO has proposed. And we don't do things exactly the way we did before COVID-19. So I will start with my first slide. which I am not seeing on my end. Perfect. Next slide. So over the next 10 minutes, I hope to convince you that there is this relationship in the healthcare setting between COVID-19 and the non-communicable diseases with special reference to hypertension. I hope that you'll be able to identify some potential public health implications, which many of us as healthcare professionals are already experiencing, especially in countries and regions where this pandemic has ravaged our health systems. Design a strategy for telemedicine, which is one of the innovations that I see coming out of this, and also to formulate a plan for remote monitoring and management of blood pressure, and maybe to appreciate some of the ethical responsibilities that we have for delivering safe care, even on a telemedicine platform. Next slide. So I think everyone kind of knows this schematic. I'm going to, however, still drill down on it because it's so important. We have all experienced, many of our countries, the ravages of this first wave, which is the immediate mortality and morbidity caused by COVID-19. It was unexpected. It was unprecedented in our lifetime, certainly. And I guess in some respect, we could also claim that our healthcare systems were not as agile as we thought they were to respond to the pandemic. And so there was the emergency need for ventilators and for drugs and for a plan. And plans evolved as this pandemic evolved. And though we cannot say that we have, well, maybe we can say now about at least one or two vaccines, certainly the way we manage COVID-19 patients has improved since we were first met with the pandemic. And then the second wave is really the impact of resource restrictions for non-urgent conditions. And I'm really going to drill into these because this is really what is the Ncds has taken a hit on. The third wave was the impact of interrupted care on chronic conditions, again, affecting the non-communicable diseases like hypertension. And the third wave, which is affecting all of us, whether we have either been directly affected by COVID-19 or whether we have had our care disrupted by non-communicable diseases, all of our patients, all of us on this planet are affected by the mental health issues surrounding COVID-19 and of course the economic issues, which we have no control over. Next slide. And so I really like this schematic because it certainly speaks to what happened in Barbados. And I'm sure it's similar to my other Caribbean neighbors in St. Lucia and Trinidad and Tobago. And I know that Jamaica is also on this call. The first services that were disrupted really are identified in this bar graph. Rehabilitation services, or the only rehab center on the island, which has just about 285,000 citizens, was rehab services at the Heart and Stroke Foundation. It closed immediately because gyms were not a safe place to be. Even if we wanted to have our staff there, certainly patients weren't going to come because they're faced with this disease, which you're seeing on social media and on the local news, is having a devastating effect in other countries. And the next thing you can see here was also relevant to Barbados and the region, and that's hypertension management. Clinics closed. Think about this. A tertiary hospital, the only tertiary hospital on the island, managing resistant hypertension cases, and all of a sudden the hospital resources, human resources, attention, the whole strategic plan shifted from the pan-NCdemic, which we became so accustomed to, focus solely and squarely on the COVID-19 pandemic. And so clinics were canceled, we rescheduled patients, they were told you need to collect your prescription from at this point, or actually the pharmacist may deliver the prescription or medication to you. We then realized that we did not have accurate contacts for patients. So some people, we just could not contact them. Obviously the mail service was disrupted, so you can't send them something in the post either. It was quite chaotic. And this occurred across several other clinics. Diabetes and diabetic complications management is shown here, asthma, palliative care, all of the Ncds, even urgent dental care, which I can speak from personal experience, was interrupted because of course, this is a high-risk environment in a dentist's office. Next slide. And if you weren't convinced that this was related at all to COVID-19, well, look at the percentage of services disrupted depending on the phase of disease spread, from sporadic cases in blue, phase 2, to cluster spread. And we were fortunate locally to only have had cluster spread. And look at the amount affected in community spread of the disease in phase 4, where almost 70% of hypertension services were disrupted. These patients did not press pause. And I really like what Dan said in the beginning of his presentation. You know, we cannot take a pause. Usually when you're faced with an emergency, like a flat tire or your roof is leaking, you kind of pause everything else and deal with that emergency. The healthcare fraternity did not have that luxury because the NCDs were presenting. So we couldn't press pause. Next slide. And then, of course, there was task shifting, which this group knows very well about task shifting because it's part of the HEARTS program. All NCD staff were partially reassigned. That was about 33%. Some of the NCD staff were partially reassigned, 25%. So that's more than 50% of reassignment. Some NCD staff reassigned to full-time. In fact, although Barbados has been quite lucky to only have imported cases coming into the island, there still hasn't been the complete reassignment of staff back to the NCD clinics. And that's an interesting phenomenon where we are so much on guard that we no longer even want the comfort of reassigning staff back into their traditional role. But guess what? The NCDs, including hypertension, they have not taken a pause. They continue. The revolving door of heart failure and all of the complications of NCDs are actually increased at our hospital. Next slide. And so this just re-emphasizes the whole building back better. 66% of countries have included the continuity of NCD services in their national COVID-19 plans. But as you can see, that's really dependent on how much money and your socioeconomic status. You know, we have vulnerable economies in small island developing countries such as Barbados, and in many countries of the region, money has to be shifted to fight a pandemic. It also has to be shifted to counteract the effects of climate change. And there are competing priorities that governments have. And so you don't have a bottomless pot of money to kind of just spend on COVID-19. And so innovation has to come in. Next slide. And how we build that back better. So countries were really asking for urgent guidance from the World Health Organization, how to provide continuity of NCD programs. And here are some questions. For instance, how to include NCDs in public health emergency protocols. Imagine a public health emergency protocol that actually spoke to NCDs, which we don't tend to see as a national emergency as we do see an infectious disease like a novel coronavirus. How to develop national NCD toolkits for use in emergencies. Now, this is where the very complex and large document of guidelines can really become quite even more cumbersome, because not only do you need a simplified algorithm that you might find on one page like the HEARTS algorithm, you have to be able to find it quickly. You have to be able to train staff who are not accustomed to managing certain conditions in the NCD outpatient clinic. And you also have to have an important person in this whole chorus on board, and that's the patient. The algorithm has to be simplified enough and simple enough that even patients, or especially patients, can understand it. And also how to provide medical care for NCDs through telemedicine and digital solutions. So any of you on the call who know me very well, including Don DePetty, who I know is shaking his head, I'm always glued to my mobile phone, so I use technology quite a lot. Next slide. Technology offered a solution in COVID-19. You know, besides social distancing, wearing a mask, protective wear, educating the public, now you have this platform that you can possibly continue care at a safe distance during a pandemic. Next slide. So telehealth is really a holistic and approach to telemedicine. It's integrated use of communication devices. There's clinical and non-clinical telemedicine can occur. And the practice of medicine to deliver care at a physical distance is really what you're aiming for. So the physician is nowhere near the actual person that, or healthcare provider, I should say, physician, nurse, pharmacist is nowhere near the patient, but is still providing care. And not just saying, calling on the telephone and saying, well, I'm just going to move you to step 2. It's having a conversation as we are now and finding out, well, how are you coping in COVID-19? Have you had any side effects? You can even have a look at the ankle edema on telemedicine. So you have that kind of authentic interaction with the patient and you're able to deliver care. Next slide. So mobile health and telemed and blood pressure really go hand in hand. It's fortuitous that COVID-19 occurred to bring this union even closer together, because certainly things should never go back the way they were before. In my hypertension clinic, for instance, in my private clinic, which is on Mondays and Thursdays, my Thursday clinic, despite only having imported cases of COVID-19 nationally, has remained as telemedicine because it's more efficient. And my nurses, having been involved in it, they've been using the H protocol of hearts remotely. I have been using the E protocol and the other protocols. So it is a seamless transition. But the most important person in the center of all of this is the patient, who's actually following the simplified protocol because he or she knows what's the next step. Next slide. So here are some do's for telemedicine, okay? Determine the type of patient you're going to see. Don't be biased by things such as, oh, well, maybe my elderly patients are not going to do too well on telemedicine. I have a 92-year-old who now has a smartphone, who probably only uses it for her telemedicine visit, but who I see via telemedicine. There's coaching and training, which is actually exciting because you're on a new platform with patients. This is new for you as well if you haven't been using it before. Patients and staff may be involved in the coaching. But here's the added benefit. You no longer have to worry about how am I going to get the patient support structure in, because relatives may be there, other caretakers may be there. They're all on the teleconsult call with you, and it provides a kind of an extended network of support. Front end, the consultation. I would say that this is probably the most important part of the consultation. Agree on what you're going to kind of discuss in setting your agenda. And then send them reminders, for instance, that the consultation is coming up, what time it is, the platform that's being used. I have to admit, my office staff did all of this work for me so that I appeared even more uncomfortable than my patients sometimes on the platform, because they've used it. They would have used it so many times speaking to the nurse about salt reduction or trying to avoid taking over-the-counter painkillers or even getting some more physical activity in. And so they were quite comfortable with it. And of course, at the end of the consultation, you have to kind of close the consultation. Next slide. Of course, you need the right attitude. I have to say that some of my colleagues entered telemedicine kicking and screaming, and dare I say coughing as well. But they really did not want, they saw it as an alternative that they really did not want to engage in, rather than an opportunity to connect with patients that you possibly would not have been able to do before. So see the platform as an opportunity. Remember, it doesn't replace the authentic face-to-face visit in many circumstances, but it is an alternative platform. And of course, we offer training through our neighborhood university I have here. So the University of the West Indies offered training for healthcare providers, because it's not as easy as it looks either. It's not just about turning on your camera and getting started. It does take training because it is a unique style of consultation. And if you are hopeless with IT, then you also need some IT support as well there. And you can use your EMR or you can use a paper-based system. It really doesn't matter. I use a combination of both. There are several platforms out there that are actually free that you can get started on. And it's always helpful to have several dry runs, not just one dry run, but several, just to be sure you're absolutely comfortable with the platform. Next slide. And this just describes one of the devices that I use, which is called the mHealth blood pressure monitoring device. So it's shown right here. I'm not sure if my scroll is coming across on your screen. So patients essentially have the device at home. They put it on, they do readings twice a day or as directed by the healthcare provider. The results all come to a dashboard. Next slide. Okay, so this is what the device looks like. It connects to your smartphone. Yes, I do have an iPhone bias, and it tracks your readings. Patients don't have to write anything because the readings all go towards the dashboard, which might have set alarms and reminders and checks. And if you're fortunate like myself and you have a nurse in your practice who's kind of monitoring these results, she can give them a call and say, well, your blood pressures are actually trending up, or your blood pressure is actually looking quite good. Maybe we can extend your appointment further. Next slide. And this slide just kind of shows what the dashboard looks like. So it gives you a lot of information, not just on blood pressure. I mean, other information you can put in there as well. So patients can do their home weight. I mean, I guess you're really looking for a change in weight. So they might be using their own home scale, which is standardized, hopefully. So you could compare whether they've gained weight, or you can do other measurements such as waist circumference if they're trained to do so. But more importantly, you can document their blood pressures and the various attempts that they've had to reduce salt, increase physical activity, decrease alcohol, especially in lockdowns, as well as attempts to stop smoking. Next slide. Okay, so my take-home points really is that COVID does represent a contemporaneous and unpredictable public health challenge. And public health mitigation measures offer some defense, but it poses challenges for non-COVID cases, such as non-communicable diseases. Delayed care will influence both mortality and morbidity, as Dan Lackland showed, related to NCDs, including hypertension, plus all the other NCDs. Remote management is a possibility for the management of blood pressure. You can actually think of blood pressure as an ideal NCD to be managed remotely, because all the gadgets that are used for home blood pressure monitoring, which is kind of what we want, are easily accessible, are quite reasonable now, and it's really just incorporating that into remote consultation. Next slide. Telemedicine allows for that type of consultation, but training and auditing are required. Do not kind of get into this just without any training. You will need some training. Standardized treatment algorithms reduce inertia, not just for the doctor, but more important, the patient who is following the same algorithm and kind of knows what the next step is. And mobile health may offer an innovative way to monitor blood pressure and other health metrics. Next slide. And I am going to finish here. And I do believe that there is a bonus slide at the end, compliments Paho. Thank you very much for listening, and I look forward to your questions. So I'm not sure if I'm meant to narrate, but it seems quite obvious to most of us dealing with blood pressure. Support the feet, keep the legs on cross. Many of our medical students know this quite well because it's a checklist that's used in their assessment of how well they are at coaching patients to take a home reading. Thank you very much, and over to you, Pedro.
Excelente, Ken, igual que siempre, muy elocuente, muy actualizado. Siempre Ken nos pone el desafío de la tecnología, cómo hacemos y qué sé yo. Quiero decirle que cuando Ken no tiene Wi-Fi es casi como está al borde del ataque, ¿no? Entonces nosotros tenemos que cuidar siempre de tener la tecnología allí disponible para poder hacer las cosas que tenemos que hacer a tiempo. A mí me ha gustado mucho un mensaje aquí que él ha dejado. Dice, postergar la atención solamente lo que hace es aumentar el riesgo de complicaciones y de muerte. Postergar la atención al paciente que requiere solamente lo que hace es aumentar el riesgo de complicaciones y muerte. Y este es un mensaje súper poderoso que a mí me gustaría que ustedes lo pasaran a sus gerentes, a sus profesores, que pasaran la voz. O sea, si postergamos lo que tenemos que hacer ahora, solamente lo que estamos haciendo es aumentar el riesgo de muerte y de complicaciones. Yo quisiera volver entonces al profesor Don DePetty en su muy elocuente presentación en la primera parte de esta sesión, y que nos hablaba del enfoque individual y del enfoque de salud pública. Déjeme decir una cosa, el profesor DePetty es un clínico de capacidad probada, ninguna duda, es un clínico, ama la medicina, ¿sí? Don DePetty tiene una fuerte formación clínica y ha dedicado su vida a enseñar. Y ahora un clínico de tan alto nivel nos está diciendo, fíjense ustedes, tenemos que tener las guías de prácticas clínicas, necesitamos protocolos estandarizados si nosotros queremos mejorar. Esto no siempre es bien recibido por algunos sectores, ¿no verdad, profesor DePetty? Ya sabemos los desafíos, porque hay algunas personas que creen que tener un protocolo estandarizado de tratamiento reduce la capacidad de decidir libremente qué le pongo a cada uno de mis pacientes, pero lo cierto es, doctor DePetty, que los niveles de control son de control de presión arterial son muy bajos en el mundo entero, ¿no verdad? E incluso en los países ricos se han deteriorado esos niveles de control y esto ha traído consigo, bueno, las consecuencias que ya sabemos. Entonces, ¿usted quisiera hacer un comentario alrededor de este asunto, por favor, que es una pregunta recurrente? Adelante.
No, Pedro, thank you. And we had the exact same issues here when we started our algorithm, which does include 2 medications in the initial management of hypertension and, of course, a fixed protocol. What I say to initially is individualized care and population public health approach is they're not mutually exclusive. As a matter of fact, they go hand in hand. Once we started initiating the algorithm, the protocol, the smaller formulary, if you will, it's important to find champions that are on the ground. And actually, I would line those champions up initially and obviously bring in all the stakeholders. Once the results came in and once we saw control rates really rapidly increasing, then the buy-in just automatically happens. But it is heavy lifting, and again, we don't want to take the individual physician or healthcare providers for granted. We need to talk to them, get them on board, tell them why we're doing what we're doing, demonstrating successive hearts in our 12 countries, our first cohorts, and now beyond. And then it's been a much easier task.
Muy bien, doctor DePetty. Yo creo que este es un tema clave, ¿no verdad? Y también tenemos que seguir insistiendo en la importancia que tiene el primer nivel de atención para manejar a los pacientes con hipertensión y con diabetes. En los sistemas que aún todavía son muy fragmentados, donde el acceso a los servicios de salud es muy complicado, hay barreras suficientes para acceder a los servicios de salud. Si no fortalecemos el primer nivel de atención, pues entonces estamos perdiendo esto que el doctor Connell llamaba hoy, ¿no? A decir, bueno, si posponemos esto, o sea, si la gente no tiene acceso a tratamiento o no tiene acceso a los medicamentos, estamos posponiendo el tratamiento, ¿no? Y esto definitivamente va a traer como consecuencia más gravedad de lo que tenemos. Entonces, ahora tenemos que hacer, el mensaje está claro, hay que tener más recursos para la salud. No estamos diciendo quitémoselos al COVID, todo lo contrario, hay que responder al COVID en la magnitud que tiene, pero sin olvidar el otro tema que teníamos que era tan grave, que es la presencia de enfermedad cardiovascular. Quisiera entonces traer ahora al profesor Daniel Lackland para que nos hablara un poco de otro tema que él mencionó en su plática y también el doctor DePetty, que tiene que ver con lo que ha pasado en algunos países, incluso en los Estados Unidos y también en algunos otros países, después de décadas disminuyendo sistemáticamente la mortalidad cardiovascular y particularmente disminuyendo la mortalidad por enfermedad cerebrovascular, hemos comenzado a ver un repunte ¿no verdad? Hay países que han disminuido esa velocidad, incluso hay países que están aumentando la mortalidad cardiovascular, y lo que hemos encontrado en el intermedio es el deterioro de los programas de hipertensión, sobre todo en el primer nivel de atención. Entonces quería que el profesor Daniel Lagner nos comentara sobre esto y también quizás vincularlo con otro tema, porque los grupos más vulnerables de la población desde el punto de vista económico también sufren con más las consecuencias de las dos cosas, de la enfermedad cardiovascular y también del COVID-19. Entonces, si usted fuera tan amable, profesor Daniel Lagner, de nos comentara sobre este asunto. Adelante.
Very good, Pedro. Thank you. I think it's a brilliant observation, but a very, very critical observation, as everyone, Ken and Don, have both emphasized. One of the thoughts is that when we were first, at least in most of the world, when we began to see the excitement from the 70s and 80s and showing that you can really lower blood pressure, and we got very enthusiastic about it. And it may have been a little bit of that kind of, I hate to say, fear or a comfort in saying maybe we've cured hypertension, which is not the truth, but maybe some other things took interest. In this case, COVID-19 is one of those things. Diabetes, other conditions, cholesterol came in and said, well, now that we've got blood pressure under control, which again was false, maybe we've kind of took our foot off the pedal and lost some of that interest and enthusiasm. I think as we begin to, so we're starting to have a little bit of a renaissance where we're bringing in a new refocus on blood pressure and knowing what we can do. For countries that are developing and a little bit behind the curve, I think what we did show from the 70s and 80s and 90s, these dramatic improvements with regards to outcomes, I think are something to show. The other piece there is I think we need to regenerate our focus, and I think that can be another piece as well, is bring back that focus to blood pressure. And in one sense, that's what Hearts is doing. That's what the Surgeon General's report's doing. That's what we're all doing right here, is saying, no, we haven't cured it yet. We're moving forward, but it's a great opportunity. But one brilliant question.
Ok, le estaba diciendo que no solamente no lo hemos curado, sino que cuando se deteriora lo que hemos hecho, viene hacia arriba de nuevo y nos recuerda que si no le prestamos atención sistemática al tema de la hipertensión y de los cuidados de la hipertensión, que tenemos que decirlo, que tiene todo el componente preventivo, pero también tiene el componente de cuidado, ¿no es verdad? Y en el balance apropiado, pues entonces eso al final nos va a venir encima. Y por eso también tenemos que decir, a veces yo me pregunto, nosotros tenemos tantas complicaciones en los pacientes con enfermedad cardiovascular porque son muchos o porque el COVID es más grave en ellos, o por las dos cosas. Después pensemos en eso en un minuto, pero tenemos que decir, tenemos muchas personas con hipertensión, muchísimas, 1,3 billones de personas con hipertensión. Es nuestro factor de riesgo con diferencia más frecuente en las poblaciones y podemos controlarlo, podemos hacer diferencia. Entonces, por eso Kenneth nos ha recordado hace un ratico que hay que hacer las cosas de manera diferente. Si todos los días usted viene haciendo las cosas de la misma manera y esas cosas no les están saliendo bien, significa que alguna cosa tenemos que cambiar. No solamente porque ahora tenemos el COVID, sino porque había que cambiarla con anterioridad al COVID. Y a mí me gustaría que el doctor Kenneth Connell volviera sobre un tema que él ha tratado en otras ocasiones. Además de la cuestión tecnológica, que es sumamente importante, es un problema que yo creo que la telemedicina llegó para quedarse. no vamos a tener respuesta así. Y hay pacientes que definitivamente se beneficiarán de la telemedicina y otros se beneficiarán menos. No, pero el sistema en general puede beneficiarse mucho. Pero yo quisiera que el doctor Kenneth Conner viniera sobre un tema que es muy importante, el papel del equipo de salud. Kenneth, como usted conoce que ha viajado con nosotros todos los países de América Latina, nuestro sistema está centrado en el médico. Y si no es el médico el que toma la presión, el que pone el tratamiento, el que siga a los pacientes, pues nadie lo hace, ¿no es verdad? Porque el resto del equipo de salud está como prisionero sin poder hacer suficiente. Y entonces una innovación en cuidado tiene que ver con el equipo de salud. ¿Usted quería hacer algún comentario sobre esto que lo hemos escuchado en otras ocasiones? Por favor.
Sure. So thank you so much, Pedro, for bringing that up. And let me just say that without the establishment, and I'm going to say this unconditionally, without the establishment of a strong healthcare team for the management of hypertension, this whole pandemic could have caused a lot more disruptions to care. And that is because the healthcare team allowed for very fast and agile task shifting and task sharing, because everyone kind of knew what everyone's role was and could kind of fit into that person's place. Remember, I started off by saying that Barbados never had community spread. We had a few clusters and now imported cases. Look at what has happened at our hospital. Our heart failure admission rates have gone up by 52%. This is just a country where people have preferred not to go to hospital because of a fear and not because of spread of a pandemic. They just haven't gone because of a fear of being infected. And as a result, because of that pause that Dan was speaking about, we now have recently, last week, our hospital announced we have no more beds. They're all filled with not COVID cases, they're filled with complications of NCDs, stroke, myocardial infarctions, heart failures that have represented. And if you take a closer look at some of these presentations, they have been because people have spaced out medications, they've just stopped taking them, they just haven't been seen. The healthcare team in Hearts allows for instance, a nurse to do a follow-up visit on a patient who is reasonably controlled or who knows what's the next step, to advise that patient to escalate to the next step. So by having a nurse that's trained basically on the same page, literally it's one page, you're able to shift, because you never know when the doctor may be shifted from the role of doing a blood pressure to intubating the patient. And these are things we have to consider. And this is why I think Hearts makes the agility of managing hypertension so much better.
Excelente, excelente. Yo creo que el consejo ha quedado muy claro, ¿no? ¿Verdad? Ha quedado muy claro. Yo voy de nuevo con Don, porque el profesor Don De Petty nos ha dicho, bueno, aquí tenemos el algoritmo de tratamiento, pero también ha hablado del tema de los medicamentos. Y ya sabemos que una de las barreras principales que tenemos en la región es el acceso a los medicamentos, ¿no? ¿Verdad? Entonces, yo quisiera también que el profesor Don De Petty nos hablara por qué, si tenemos un protocolo estandarizado de tratamiento, también podemos optimizar la utilización de medicamentos y por qué podemos hacer que los medicamentos estén más disponibles para los pacientes. Así que esa es otra de las ventajas que tenía un protocolo estandarizado de tratamiento. Profesor De Petty, por favor.
Pedro, absolutely. And I've made this comment before, so pardon me if you've heard it before, but all politics is local. You know, all real estate is local. So that's why it becomes very important for we are developing recommendations, we're developing blueprints, but we're not mandating. That's why the countries, the cohorts have been so successful in Hearts in America, because they developed the protocols. They knew the accessibility of the medications. They knew what they could afford. They knew what was culture, what physicians and providers would accept, and also what they wouldn't accept. And I think that's why it's been so, that's one key point as to why it's been so successful. And again, we did the stepwise approach. Start with a current protocol. Dr. Skeeth is going to review a paper that emphasizes that shortly. But then also start planning the ideal or the acceptable protocol, and then the preferred protocol. It never stops. But the most important thing is get going. Start somewhere and start now, not yesterday.
Excelente. Siempre un mensaje de que es un desafío, pero podemos hacerlo y tenemos que hacerlo ahora. No se puede quedar esperando, porque ya nos habían dicho que postergar la atención solamente aumenta el riesgo de complicaciones y de muerte. Profesor Daniel Lagman, tengo otra pregunta por aquí para usted. Bueno, ahora se van a poner más pequeños los recursos todavía de lo que antes teníamos. Eso es lo que estamos esperando que ocurra, ¿no? ¿Verdad? Los sistemas de salud se han quedado exhaustos, los gobiernos están exhaustos, tenemos una crisis económica real, tenemos más riesgo de que no se atiendan correctamente. Entonces, en esas circunstancias, los que dirigen los servicios de salud, los ministerios de salud, los políticos, requieren escuchar personas de usted, de su nivel, de un profesor de tanto prestigio, diciéndole, bueno, profesor Lagman, ¿y cuál es la prioridad? ¿Qué usted nos aconseja si nosotros tuviéramos que hacer 2, 3 cosas? ¿Qué es lo que podemos hacer para arrancar este camino y retomar el paso? Porque ya sabíamos que el riesgo de llegar al 2030 y no cumplir con los objetivos de desarrollo sostenible ya eran altos antes del COVID, ahora son más altos después del COVID. ¿Qué usted le diría a los políticos para que nuestra audiencia clínica también y nuestro centro de HART le digan a su gente, esta es la prioridad? ¿Qué deberíamos hacer? Adelante.
Very, very nice. The first thing I would do is remind the politicians about history. Remind them what may be what some of us believe was the best in the 20th century, the best public health success rate, the success story, and that was the control of blood pressure and the reduction of disease, stroke, and looking at those declines, a true success story. We can even see Franklin Roosevelt, President of the United States, had a systolic blood pressure of 300 right before he had a stroke and died. We don't see that anymore. We see high blood pressure, but we don't see those strokes that were those blood pressures that were so excessive. So we know that it can be there. We know that it can be a success with things like, and now we have the agents. I mean, just look what Hearts is doing. Hearts is actually an economic plan as well. It's the team approach. Again, that was beautiful. No, the physician doesn't need to measure the blood pressure. And Don, you come up, those are reasonably priced drugs. We're not pulling out an agent that's going to cost somebody hundreds of dollars a month. It's very, very economic. We have telehealth, where now you can reduce the cost associated with the meeting, and very importantly, you have home blood pressure monitoring that you're promoting right up in here. So now the patient takes role, or the population takes responsibility for themselves. Measure your blood pressure, know what your blood pressure is, and implement that with and complement the medical care system so that you're not putting a burden on it. If you're controlling your blood pressure the way you're able to, maybe I don't need to come in and burden my physician and my team right there. So I think it's a beautiful model based on evidence, based on success, and I just need to facilitate it. And and with the politicians saying this is our top priority, but we know that we can do it.
Excelente, excelente. Profesor Kenneth Connell, fíjese lo que le voy a decir ahora, a ver si usted recuerda esto. A finales del 2016, cuando estábamos allá en Chile, teníamos 4 países y 7 centros de salud implementando HART. Finales del 2016. 4 países, 7 centros de salud. Hoy tenemos 15 países, 12 países implementando, 3 países más comentando la implementación, y tenemos 372 centros de salud alrededor de la región. Pero todavía hay países que no se han sumado, ¿no? ¿Verdad? Tenemos 15, podemos tener yo creo que vamos a tener 17 en unos días. Y recuerde que nosotros, el equipo de HART, hemos dicho, toda la comunidad de HART, al 2025 HART será el modelo de cuidados cardiovasculares en esta región. Entonces, usted le puede mandar un mensaje, ¿por qué la atención primaria es clave? ¿Y qué usted le diría a los países que no han tenido demasiado empeño, iniciativa, deseo, o no han podido sencillamente incorporarse a HART? ¿Cuál es el mensaje que usted les pasaría? Adelante, profesor Kenneth Connell.
I think our message has to change now, Pedro, and I think it has to reflect the current world that we live in. Our message now has to be that it is so important for you to get your NCDs under control, because you could be faced with a pandemic like COVID-19, or God forbid, COVID-25 or 42 or whatever in the future. And therefore, your communities could be at significant risk. It's not just the chronic clock ticking on a daily basis of MIs and strokes and heart failure, because if that isn't bad enough, you now are creating high-risk populations by not controlling your NCDs. And so here's HARTS. Not only is it addressing the chief and the primary driver of these events, hypertension, but it's a simple roadmap, because guess what? Your health services may be called to do other things, like fight a pandemic, but now you have a roadmap that's simplified enough that you can easily take it up. People can get on board a team. The team can become really good at what they do. And even if task shifting has to occur, if something happens in the future, you still can continue. I think HARTS is even more relevant post-COVID-19 than it was before. But I think we need to kind of get that message out there to the rest of the world.
Bueno, excelente, excelente. Entonces, yo, antes de pasar al próximo bloque, vamos a tomar una pausa activa para que se muevan un poco ahora nuestros colegas de Santa Lucía. Nos van a poner a mover el esqueleto, porque la obesidad y la falta de actividad física, junto con el aumento del consumo de sal, son gravísimos y matan definitivamente. Entonces, adelante nuestra pausa activa y tomenos unos segundos para regresar en un ratito. Adelante.
Today let's make a start. It's good for the heart. Somebody say it is for health, it is for health. Give me the E for energy, E for energy. It's for all our way, it's for all our way. Give me the R for ready, R for ready. The G, the S, take the test. The T, the S, team no stress. H-E-A-R-T, K is the remedy. If you want the hope in the Lord, bring it help your heart. All you get up and start to. All you get up and start to.
Bueno, regresando. Es una pausa, una mini pausa activa, ¿no? Hay que hacer un poco más ejercicio que esto que estamos diciendo aquí ahora, ¿no? Pero definitivamente volvamos entonces a la segunda sesión y posiblemente nos quede algún espacio para volver con nuestros panelistas, porque tenemos un montón de preguntas, pero el tiempo se nos va, ¿verdad? Así que en esta segunda sesión vamos a presentar lo último que tenemos en noticia, también derivado de nuestras approaches en HART, ¿verdad? Que tiene que ver con lo que ha sido publicado recientemente. Yo tengo el placer de nuevo de regresar a ustedes el profesor Donald de Petty, que como ustedes saben es profesor distinguido de la Universidad de Carolina del Sur. Yo no tengo miedo de repetirlo, ¿sabe por qué? Porque al principio, cuando comenzamos este webinar, teníamos 200 y tantos participantes, pero ahora tenemos el doble. Entonces no hay que tener miedo a repetirnos algunas cosas. Adelante, profesor de Petty, usted tiene el micrófono. Adelante.
Thank you very much, Pedro. Let's go ahead then and move on to the second session, which really I think is a very interesting and unique opportunity, and that is to discuss late-breaking journal club headlines. We are fortunate to have Dr. Skeeth with us from the Division of Cardiology and Rush Medical Center and University in Chicago. And Dr. Skeeth is going to discuss two papers that recently came out that several of us, of course, a little bit biased, a little bit prejudiced here, I must admit, participated in. And the first publication is going to be Approaches to the Management of Hypertension in Resource-Limited Settings, but specifically strategies to overcome the hypertension crisis in the post-COVID era. Dr. Skeeth, why don't you go ahead and review this paper for us, discuss its importance and more importantly, its implications, and then we'll talk about the second paper.
Thank you, Dr. DePetty, for your introduction. And I'd like to also take this opportunity and use this forum to congratulate Dr. Arjunis and the entire PAHO community for the excellent work that's being done in addressing the hypertension crisis that is currently plaguing not only places within the Caribbean and Latin America, but across the globe as a whole. I recall when this pilot was started in Barbados almost 6 or 7 years ago, how much effort was made, and it's fascinating to see how widely it has been taken throughout the region. So as Dr. DePetty would have mentioned, I'm a member of the Division of Cardiology at Rush University Medical Center here in Chicago, Illinois, in the United States. And the first paper that we'll be discussing is the approaches to the management of hypertension in resource-limited settings, and it will be focusing on looking at strategies to overcome the hypertension crisis in the post-COVID era. Now, the main aim of this particular manuscript was to explore the overlap between the COVID-19 pandemic and the hypertension crisis. Initially, we thought of these as two distinct entities, but there are a number of significant lessons that can be learned from the approach to the management of COVID-19 that can be applied to hypertension, and we think that this is something that is worth highlighting. And then we think that we should describe a framework for the management of hypertension based on these lessons learned. Now let's start by looking at the hypertension paradigm, and a lot of this is based on the COVID-19 paradigm that we've seen unfold before us. Like with the COVID-19 pandemic, there was a big discussion about addressing risk factors, and in hypertension is identifying the risk factors that have traditionally been unaddressed. In hypertension paradigm, there's significant failure to diagnose hypertension in large segments of the population. There's traditionally low treatment rates and poor cohort monitoring. Ultimately, inadequate treatment to goal or target blood pressure. And what this translates to is low control of hypertension as a whole and high complication rates. And tying this into what we have seen with the COVID-19 pandemic, where risk factors such as social distancing and use of masks has been elusive in some populations or in some settings. Large segments of the populations have failed to be diagnosed, or their true COVID status has not been identified. In some instances, persons who are positive are not able to isolate themselves or take the necessary precautions to prevent spread. Ultimately, these persons go on to lead to more people becoming infected and high complications rate. So you can see that there's definitely some similarities between these two paradigms. So how can we go about improving hypertension control using this framework? So go ahead and in step 1, address risk factors. Step 2, determine the true prevalence of hypertension. Step 3, improve the framework for the standardized treatment and management of hypertension. And step 4, improve cohort monitoring. And a number of these steps are integral parts of the HEARTS program as well. So the manuscript goes to great length to describe the interplay between hypertension and the COVID-19 pandemic. So we've seen in the media and through organizations such as the World Health Organization and PAHO the need to address risk factors for the spread of COVID-19. And translating this to hypertension, we too have to identify and address risk factors that are resulting in spread of hypertension. And these strategies to reduce these risk factors, such as reducing salt consumption, increasing levels of physical activity, maintaining a healthy weight, use of healthy foods, particularly plant-based nutrition, and avoiding tobacco products and following medical advice must be the message that we use to decrease the spread of hypertension. The second step is to determine the true prevalence of hypertension. The COVID-19 pandemic, there was discussions, or there continues to be discussions surrounding widespread testing and developing a framework to permit population-based testing. And the same is true for hypertension as well, where we need to devise strategies to permit widespread testing of large segments of the population, such that persons who may be hypertensive but not diagnosed can be identified and ultimately channeled into treatment. Now, a third area of interplay that was identified in this particular manuscript was the need to improve the framework for the standardized management of hypertension. Now, this image comes from my own hospital, Rush University Medical Center, where we had to significantly increase our capacity to treat persons in the initial surge during the COVID-19 pandemic. And what we did here is utilize one of our waiting areas, our pavilion, to manage persons who are presenting to the hospital with symptoms consistent with COVID-19. The same improvement in the framework has to be applied to hypertension. I think no better system to date, at least in the Americas, has been described as that of the Hearts in the Americas Initiative, which features several strategies to improve the framework for the management of hypertension, which has been discussed at length by some of our other presenters today. And finally, the fourth and probably one of the most important steps is that of improved cohort monitoring. In the COVID-19 pandemic, one theme that became particularly apparent was the need for contact tracing and following persons to see whether or not they have developed symptoms consistent with COVID-19 and ultimately have them tested and treated, or at least take precautionary measures to prevent further spread. And the same must be applied to hypertension, in which we have to, one, be able to ensure that larger numbers of the populations know their actual hypertension status. We're able to follow them through to treatment and ultimately determine whether or not our populations are reaching blood pressure targets. So the main take-home point of this particular manuscript was that the hypertension crisis, like the COVID-19 pandemic, is a real one, and it requires the attention that is currently being received by the COVID-19 pandemic. Like the COVID-19 pandemic, there is a dire need for decisive action to address the factors that have resulted in the high prevalence of hypertension and institute measures to decrease its spread. Similarly, the main take-home point is that the lessons that are being learned in the aggressive approach to the management of COVID-19 must be applied to the hypertension pandemic as well. Now, along similar themes, the second manuscript, which was published in the Journal of Clinical Hypertension with a number of authors across the Latin America and the Caribbean region, as well as international authors in Europe and North America, is the standardized treatment to improve hypertension control in primary care. Now, that's at the Hearts in the Americas Initiative. Now, again, this manuscript is particularly timely, as was alluded to by Dr. Connell, where the need for the control of hypertension as a strategy to prevent negative outcomes in pandemics such as the COVID-19 pandemic is even more apparent now than it has been in the past. And this manuscript covers some of these aspects. The main aim of the manuscript was to describe the adoption of the evidence-based protocols, or Module E of the Hearts protocol that Dr. DePetty would have mentioned in his initial presentation. As he would have mentioned as well, one of the key points that was identified in this particular manuscript was the features or the ideal characteristics of antihypertensive medications. And I think this point is so important that I will reiterate some of what he would have said before. These medications, as was mentioned in this manuscript, must have a high efficacy. They should have an additive or a synergistic approach to blood pressure reduction when used in combination. Their use should be supported by evidence-based clinical trials. They should have limited side effects. They should be affordable, available, and easily titrated. And when possible, be formulated as a single dose combination therapy. The manuscript then describes steps to build in a hypertension protocol. And I would define these as three major steps that the manuscript highlights. The first step is to select the drug classes that we want to use in the management of hypertension. And these would include drugs that are part of the renin-angiotensin-aldosterone system, such as ACE inhibitors and ARBs, calcium channel blockers, diuretics, and begrudgingly the use of beta blockers if indicated for other reasons. Step 2 is within each of these drug classes that we have identified, selecting the agents within these drug classes that are available in the particular environment in which we are practicing. And then the third and probably the most important step is to build a treatment algorithm using drugs within each drug class which meet the definitions of ideal characteristics. Now, one of the particularly important messages that was defined in this particular manuscript was the need for shifting to a preferred protocol. Dr. DiPetti would have discussed this in his introductory statements as well. So in many environments, we already have a quasi-protocol that is in place. In many cases, it's not formalized, but there is, on the ground, some form of practice that providers are using. What is important is that this needs to be standardized using the drugs that are available right now in that particular environment. And we've chosen to define this as a current protocol. But it is not desired to stay at that current protocol. With time, the desire should be to align your prescribing practice to a more acceptable protocol, where the drugs that are being used have improved properties compared to those that are being used at baseline. Now, normally these drugs may be already available on the drug formulary, but for whatever reason may not have been popular amongst the prescribing providers. The ultimate goal is to transition prescription practice to that of a preferred protocol, which can be likened to best standard of practice. Now, this may require changing or adding drugs to the drug formulary, which are more efficacious and have been shown to be better or have improved outcomes in the treatment of hypertension. Now, the manuscript also gives an example of what might be a current protocol and how that may be adjusted or changed to a preferred protocol. So taking the example provided here, in this protocol, the first step to the management would be to use the ARB losartan and amlodipine. And if blood pressure is not at goal, to titrate the dosages. If the blood pressure still is not at target, add in a third drug such as hydrochlorothiazide. And if further follow-up shows that blood pressure still remains not at goal, increasing the dose of hydrochlorothiazide even further. And ultimately, if blood pressure control remains elusive, referring the patient to a specialist or adding a fourth medication. Now, changing this prescribing practice to a preferred protocol could look something like this. Instead of using a short-acting ARB like losartan, perhaps consider a long-acting ARB like telmisartan. And we have identified that amlodipine is probably the most commonly prescribed calcium channel blocker. So we don't really have any recommendations for an alternate agent in this setting. Now, if you look at step 3, the diuretic of choice is chlorthalidone in the preferred protocol compared to hydrochlorothiazide. And so on, the protocol continues similarly with the up-titration of doses, as well as the need to refer to a specialist, as well as to consider fourth medication if blood pressure control remains elusive. So the main take-home point from this particular manuscript is that the use of a stepwise approach to the introduction of a hypertension protocol could lead to improvements in blood pressure control, as well as lead to improvements in outcomes in hypertension. It should be a target that we try to establish persons on ideal medications with time, but recognize that this may take several months to even a year to achieve. So those are two of the manuscripts that we identified that we think are relevant to the discourse that we're having at this time. The first manuscript speaking about the COVID-19 pandemic and ways we can use the lessons for that pandemic to improve outcomes in hypertension. And secondly, using one strategy of improving the pharmacologic management of hypertension, using a stepwise approach to algorithm development and improving the quality of the drugs that we use in the management of hypertension, which, as mentioned, is particularly relevant in the current discourse that we're having. All right, I'll thank you for your attention, and I'll hand it back over to Dr. DePedro.
Jamario, thank you very, very much for a very succinct review. We also have these two papers, of course, available to the group today, and they are both open access and they're readily accessible. Dr. Adunis, I'd like to turn it back over to you now. I know we have a third paper that comes from PAHO and or how you want to move forward in terms of moderating. But again, we appreciate the time that you've given not only us as individuals, but this topic, which is extraordinarily timely and appropriate.
Excelente, excelente, Yamario, excelente presentación. Muchísimas gracias por tu siempre oportuna contribución al programa HARD desde que tú estabas en Barbados, ¿verdad? Y todo lo que hemos trabajado juntos para conseguir estos resultados. Así que muchísimas gracias, un gusto tenerte aquí y que el profesor De Petty te haya invitado también, ¿no? Para que compartieras con nosotros este momento tan relevante. Estamos llegando al final de este webinar. Yo quiero recordarles que tenemos 400 y tantas personas todavía conectadas. Esto es el doble de lo que teníamos al inicio. Hoy es lunes. Es un día un poco raro, ¿no? Pero es que teníamos un montón de webinars de diferentes cosas y por eso exploramos hoy qué tal nos iba con un lunes, pero solamente por el canal de Zoom. Hay otras plataformas como YouTube que están escuchando este webinar en vivo, así que y la otra cosa que tengo que decirles antes de pasar a la última presentación, que va a ser también muy relevante, es que estas presentaciones van a estar colgadas en la página web de HARD en las Américas. Esta grabación, todas las láminas, este webinar completo va a estar a disposición de ustedes, que quiere decir que ustedes lo van a poder pasar a sus colegas que sabemos que están muy ocupados ahora. Bueno, en los días pasados tuvimos una agradable noticia también, y es la actualización que está haciendo la OPS para contribuir al apoyo a los países sobre las terapéutica, el tratamiento que está funcionando para COVID-19. Y uno de sus líderes, el doctor Ludovic Rebey, nos va a presentar hoy un resumen de lo que le han dado en llamar una revisión sistemática rápida de lo que tenemos de avances en la terapéutica de COVID-19. Así que me parece muy oportuno. Bienvenido, Ludovic. Muchísimas gracias por tu participación. Adelante.
Pedro, muchísimas gracias. ¿Me escuchas bien? Perfecto. Bueno, muchísimas gracias, Pedro, nuevamente por la invitación, y a todos los colegas de HARD, felicitaciones pues por todos los avances y por toda la información que han presentado hoy en estas excelentes presentaciones. Y yo quería realmente muy rápidamente contarles sobre la revisión sistemática viva de intervenciones que tenemos. Esta es una revisión que venimos haciendo desde abril de este año, obviamente, y que inició inicialmente con la búsqueda de estudios que eran más estudios in vitro y muy pocos estudios de serie de casos que había pues en su momento. El objetivo como tal pues de nuestra presentación de este estudio es recopilar realmente toda la evidencia sobre opciones, potenciales opciones terapéuticas sobre las que hay digamos, evidencia proveniente tanto de ensayos clínicos aleatorizados, como en algunos casos sobre cuando no hay ensayos clínicos aleatorizados, y también son, digamos, intervenciones potenciales importantes, sobre también estudios observacionales. Entonces, lo que hemos venido haciendo es utilizando, pues, unos métodos que son, por un lado, hacer una revisión sistemática rápida, utilizando métodos como Cochrane para identificar la búsqueda de revisiones sistemáticas. Por otro lado, pues, estamos utilizando el sistema GRADE, que nos permite evaluar la calidad de la evidencia que tenemos. Y por último, como un mecanismo y entendiendo pues que hay un gran número de revisiones sistemáticas que vienen siendo publicadas, diferentes colaboraciones entre las que también nosotros hacemos parte, pues buscando en estas revisiones sistemáticas también y mirando y obviamente validando el trabajo que nosotros venimos haciendo con nuestra revisión. Lo que quería en principio sobre todo comentarles era, y resaltarles era, por un lado, que la búsqueda que nosotros hacemos de estudios es una búsqueda realmente muy comprensiva y para esto nos hemos asociado con, por una parte, OMS, desde el inicio de la pandemia estructuró pues un buscador en que identifica una gran cantidad de diferentes fuentes en diferentes idiomas. Y segundo, con epistemónicos, que es un buscador que tiene más de 41 bases de datos, incluye obviamente los preprints, incluye bases de datos en diferentes idiomas, y es la que hemos visto, identifica pues de manera casi que inmediata los estudios sobre los cuales pues, nos hemos ido focalizando. Al inicio de la pandemia nosotros intentamos inicialmente tener como una priorización de cuáles eran las potenciales opciones terapéuticas y posteriormente, adicionalmente, hemos venido agregando cualquier ensayo clínico aleatorizado de una intervención nueva, lo estamos incorporando, de tal manera que no tenemos como un límite como tal de las intervenciones, sino en la medida de que existe la evidencia, vamos haciendo por la incorporación de estos. Un segundo punto que quería resaltar es el tema de la valoración de la evidencia, porque ustedes se han dado cuenta con la infodemia pues que hay cientos de estudios primarios, reportes de casos, estudios observacionales, series, ensayos clínicos, ensayos aleatorizados. Entonces, para esto nosotros usamos el sistema GRADE, que nos permite precisamente entrar a mirar, por un lado, arrancamos desde el tipo de diseño de estudio, y esto nos permite hacer una valoración de la evidencia. Ahora les muestro un poco más de detalle. Y también miramos los estudios observacionales. Y sobre cada uno de estos estudios, y es algo que se encuentra en nuestra revisión, miramos varios factores. Miramos el riesgo de sesgo, miramos el tema de la inconsistencia, miramos también si la evidencia es directa o indirecta, miramos la precisión, que tiene que ver con el intervalo de confianza, y obviamente pues el sesgo de publicación. Estos son, digamos, componentes, y yo no quiero entrar en detalle, obviamente, porque son aspectos metodológicos, pero lo que busca en concreto es que lo que estemos nosotros presentando dentro de nuestra revisión realmente vaya más allá de simplemente mostrar los resultados de un estudio, de un intervalo de confianza y decir que tal estudio fue significativo o no fue significativo. Estamos entrando realmente a hacer la evaluación completa, hacemos también los diferentes metaanálisis y en base a esto pues hacemos la valoración concreta de lo que debemos ir haciendo. Y para eso entonces posteriormente clasificamos este nivel de la calidad de evidencia en elevado, moderado, bajo o muy bajo, dependiendo pues, como les dije, no solo si es un ensayo clínico aleatorizado o es un estudio de observación, sino también de estos factores que les comenté, de riesgo de sesgo, inconsistencia y todos los demás. ¿Qué quiere decir esto al final del camino? Cuando yo tengo evidencia de alta calidad, lo que estoy diciendo es que es muy poco probable que nuevos estudios cambien la confianza que se tiene en el resultado estimado. Y cuando, por ejemplo, es muy baja, cualquier resultado estimado es muy incierto. Entonces, entre esto hay una valoración, y esto es lo que usa pues como tal GRADE. Y entonces eso es sobre los métodos, porque pues no tenemos mucho tiempo, pero sí, como les quería decir, entramos muy concretamente en utilizar pues todos los estándares recomendados internacionalmente. Y sobre los resultados, esta es una tabla de resumen que ustedes pueden ver sobre los los resultados que tenemos. Entonces están todas las intervenciones. Tenemos en este momento más de 125 ensayos clínicos aleatorizados para cada una de esas intervenciones que están ahí. Y tenemos además un número importante de estudios observacionales en una segunda tabla, pues que no, por cuestión de tiempo no voy a precisar, pero sobre la cual también estamos haciendo pues las evaluaciones. Y aquí entonces aparecen adicionalmente, teniendo en cuenta pues que esto es una revisión rápida, esta es la publicación número 11 que hemos actualizado ya. Entonces el foco de nosotros no es reemplazar como tal una revisión sistemática donde se haga pues con todos los diferentes desenlaces. Nosotros nos enfocamos en unos desenlaces que consideramos críticos desde el inicio. Esos desenlaces pues tienen que ver obviamente con mortalidad, con intubación de los pacientes, con eventos adversos y también en aquellos que son profilácticos con si hay aparición de enfermedad sintomática o no. Como ustedes pueden ver, esto es un resumen general de todo lo que tenemos en la revisión. Y cuando está el color verde quiere decir que realmente hay evidencia y que esa evidencia es o de alta calidad cuando es un verde fuerte o de la calidad es menor cuando es un verde mucho menos fuerte, en que hay un efecto benéfico. Cuando estamos seguros de que hay de que puede haber daño, entonces incluimos entonces el color rojo. Y cuando no hay entonces ninguna evidencia, ponemos el color negro. Cuando hay una incertidumbre muy alta, porque no hay realmente mayor evidencia, ponemos el color gris. Y algo que quería resaltar era de esta gráfica, que es algo que nos preocupa bastante, es obviamente hay una gran cantidad de intervenciones que tienen ensayos clínicos, pero la mayoría de esos estudios no nos están dando información tan relevante sobre los desenlaces importantes, porque se están concentrando o bien en desenlaces subrogados, que son por ejemplo carga viral o otro tipo de desenlaces, pero no están realmente evaluando mortalidad, no están evaluando, digamos, los desenlaces fuertes que necesitamos, y se están haciendo ensayos clínicos con tamaños de muestra muy pequeños, ¿sí? Entonces esto realmente puede ser problemático. No voy a entrar en mucho detalle, pero quería mostrarles básicamente es cuando ustedes entran a la revisión, que de hecho puse el enlace en el chat, si quieren acceder a ella, van a encontrar varias tablas y figuras, entre ellas que son como el resumen de los resultados, pero las más importantes son para cada una de estas intervenciones tenemos la descripción de cada uno de los ensayos clínicos aleatorizados que han sido incorporados, tenemos la evaluación del riesgo de sesgo y la calidad pues, de cada uno de esos estudios, tenemos cuando es factible los diferentes metaanálisis que se pueden hacer con esos resultados, y adicionalmente tenemos las tablas en que hacemos la evaluación completa de la calidad, como les decía, pero adicionalmente ponemos información de realmente sobre 1000 personas, cuál es el efecto que tendría una intervención en concreto para los desenlaces que les había comentado, que son mortalidad, ventilación mecánica, la resolución de síntomas y eventos adversos, etc. Estos son pues algunos ejemplos de algunos metaanálisis. Este es por ejemplo de profilaxis de hidroxicloroquina, que ha tenido pues, este es el de mortalidad en pacientes de cuidado crítico. Son más en profilaxis con hidroxicloroquina, donde están, y este es como un resumen al final del camino que hacemos en poblaciones como por 1000 pacientes, para cada uno de estos desenlaces, como digamos cuál es el efecto real que se tiene cada 1000 personas cuando se da este tipo de intervenciones. Entonces no voy a entrar en mucho detalle, pero este es el tipo de información que ustedes pueden encontrar. Estamos publicándolo más o menos cada 2 a 3 semanas esta revisión sistemática. Nuestra revisión, el objetivo principal es tener información para los Estados miembros, para los ministerios y para pues, el público en general. De ahí que nosotros lo sacamos con una publicación de OPS, o sea, no estamos entrando a hacerlo en publicación de revista como tal, porque no estamos buscando, digamos, lo que más aporta esta revisión, además de la calidad metodológica, es que tiene la información casi que día a día, ¿no? O sea, nosotros todos los días estamos incorporando los estudios que salen, y aunque la publicamos cada 15 días, cuando hay necesidad, inmediatamente estamos entregando los resultados. Y lo último que quería mencionar es que adicionalmente, con los resultados de estas revisiones sistemáticas y de otras que hacemos, tenemos guías de manejo tanto en pacientes leve y moderado como en pacientes críticos, severos y críticos, y estas guías son hechas todas con Gray y también están disponibles en la página del OPS para el manejo de los pacientes. Entonces, muy rápidamente, eso era lo que les quería comentar y bueno, te agradezco muchísimo, Pedro, el tiempo. Sabemos que es muy corto y tal vez fuimos un poco rápido, pero queríamos mostrarle muy rápidamente como los resultados principales y la metodología clave sobre la cual está siendo desarrollado. Bueno, muchísimas gracias.
Muchísimas gracias, Ludovic, por tu participación. Yo creo que una de las cosas que trae este webinar es que amplifica mucho las cosas que nosotros estamos haciendo a un público que está interesado. Y por eso yo insistía al inicio del webinar, pasen la voz, pasen la voz, pasen la voz. Pueden ir a los documentos que está produciendo la OPS para apoyar a los países como estos que estaba mencionando Ludovic, que son de acceso abierto. Pueden ir a la página web de HART, donde van a tener allí grabado todo este webinar y donde van a tener todo el material que hemos estado compartiendo con ustedes hoy. Estamos llegando al final. Le voy a pedir una última ronda. Quiero que todos los exponentes ahora, por favor, abran su cámara para la despedida y las palabras finales, porque no tenemos mucho tiempo, pero quería antes de eso saludar de nuevo a nuestros donantes y nuestros socios, particularmente a nuestros colegas de CDC y de Resort to Save Life, por su contribución a que sigamos generando información y atracción a los materiales que producimos en HART. Estoy también saludando a nuestro equipo de CMU, de NMH y también de HART en Washington, y también a nuestra comunidad de países HART que nos inspiran a seguir avanzando. Y como siempre le decimos, tienen que seguirnos proveyendo información y preguntas sobre qué a ustedes les gustaría que trabajemos en HART, cuáles son los puntos que vale la pena que pongamos en este webinar. Hemos tenido más de 400 personas vinculadas, es un número. Seguimos avanzando seguramente, y quiero entonces finalmente a nuestros speakers principales del día de hoy que nos han traído a este webinar el tema enfermedad cardiovascular y COVID-19, que le pasen un mensaje a nuestros países. Voy a comenzar primero por el doctor Kenneth Connell en Barbados. Kenneth, no sé cuán lejos está la tormenta que hay por ahí abajo por el Caribe ahora, ¿no? Pero hay una tormenta también por abajo por el Caribe y que nos tiene a todo el mundo un poco preocupado. Así que, ¿cómo tú ves esto? ¿Qué información tú le dices? ¿Qué mensaje tú le pasas a los países HART que te conocen también? Adelante. Okay.
So I would want to say, Pedro, that there is another storm, and it's an NCD storm, and it's currently in our midst every day. It's here. And although we're facing a pandemic, which is potentially with its surges and its peaks and troughs, we have to kind of realize that the baseline climate is not stability. It's a brewing pandemic of NCDs, and we need to take action. HARTS offers an opportunity to do this in a very structured way, and it's propelled even more by COVID-19, where the requirements of health systems are being shifted to COVID-19, and therefore we need to do things better. As WHO has said, we need to build back better using innovation.
Pues excelente, esa es la tormenta que venía por el Caribe, ¿no? Y que está subiendo ahí abajo diciendo la NCD, la hipertensión está ahí a la puerta, y el COVID, afortunadamente, sabemos más de COVID hoy, sabemos un montón de cosas que no sabíamos cuando esto comenzó, pero estamos lejos todavía de tener una solución, ¿no? ¿Verdad? Estamos lejos de tener una solución y hay que pasar de a poco a nuevas medidas. Quiero preguntarle al profesor Daniel Dangan, ¿qué nos aconseja? ¿Cuáles deberían ser los próximos pasos? ¿Qué usted le diría a la comunidad de países HART?
Pedro, I'd like to follow up on you and Ken and on Don there too. The first thing is with the COVID-19, we're learning every day, as you said very well, we're learning new lessons and we're learning how to treat. With hypertension, the evidence is here. We have solid evidence that everyone knows how to do. So we're ready to implement. We're not waiting for anything. We're ready to go and can be very, very successful. The new pieces that things like Hearts and the group has said here today is just kind of a new way of implementing the evidence that we knew. An implementation science, I guess, is where we are now, where you have the healthcare team that's being a part, and then also the patients are being a part now too. So everybody can be in on this and can make a tremendous difference. We know it can make a difference. And to go to our earlier statement, it is cost effective. This might be the most cost effective thing that we could possibly do, and bringing it through. And this is a document for now implementation to address, which not necessarily the COVID-19 pandemic, but certainly the pandemic of hypertension and hypertension outcomes.
Pues excelente reflexión y tenemos la tormenta tenemos el huracán que significa el COVID, tenemos nuestra pandemia crónica de enfermedades crónicas, hipertensión, tenemos también, esto sí es en serio, hay una tormenta llegando a Centroamérica, Honduras ahora mismo, ¿verdad? Quiere decir que también tenemos fenómenos climatológicos. Todo esto está haciendo que la situación sea peor y que los servicios de salud para mucha gente sea peor. Entonces quiero finalmente pasarle la palabra al profesor De Petty para que nos dé un mensaje de optimismo, de esos mensajes de optimismo que Don siempre nos da, que siempre encuentra un camino para decirnos, mire, sí, hay un desafío, pero hay una solución. Adelante, profesor Don De Petty.
Well, thank you, Pedro, and thank you for allowing me to be involved and to continue to be involved in the Hearts program. I guess we've come full circle in this webinar. We've started with the very first slide in the overview presentation of the COVID-19 pandemic and the NCD, a chronic pandemic, if you will, or crisis, if you will, forming the perfect storm. And we've ended discussing the perfect storm, as Dr. Connell and Dr. Lackland has suggested. And I'm referring to hopefully everybody will be safe with the storm in the Gulf, but of course I'm referring to COVID-19 and NCD, their devastating interrelationship. But I think that out of challenges comes opportunities. So let's turn this around. Let's turn it around into a moment of opportunity. There's been a lot written on change theory. We've talked about this actually in some of the Hearts sessions when we've visited countries. And the change theory starts with a burning platform. If we don't have a burning platform, systems just do not change. Health systems don't change. Individuals don't change. There is no question we have a burning platform. The burning platform is not only the COVID-19 acute pandemic, but the chronic NCD pandemic, which is upon us. And that burning platform, I think, I'll say it again, the United States has been at this for maybe 4 or 5 decades. And for the Surgeon General to come out with a specific report, which time is money and energy is energy, and to put his name behind a call to action for hypertension just a month ago, I think speaks volumes regarding the burning platform that we have. And again, use it. Let's use the United States' experience where we had success and now we seem to be slipping. On the other hand, the Hearts countries, the 12 cohorts already that have already implemented the Hearts program has given me tremendous hope and enthusiasm. And I welcome the other 3 Hearts countries, the 5th cohorts, if you will. And I look forward to hopefully someday, sometime, doing all this in person again. We can do it. We've done it already. Let's build upon our success.
Excelente mensaje. Yo decía que siempre el profesor Don De Petty nos da un mensaje positivo al final del día, ¿no? Y yo creo que hoy hemos maximizado un tema, ¿no? Tenemos 12 países implementando HEART, tenemos 3 nuevos miembros de HEART y queremos seguir avanzando porque lo importante es que este mensaje de la hipertensión llegue fuerte y llegue claro en el momento que tiene que llegar y sea un arma de primera mano para enfrentar los nuevos retos en la etapa todavía COVID, pero también en la etapa post-COVID. Le pido a todos nuestros colegas, Yamario, Gloria, Cintia, Jenny, el resto de los que están, Ludovic, que pongan sus cámaras. Vamos a hacer la foto final de los participantes, que siempre la tenemos, para saludar a nuestro público que está ahí. Hay un montón de gente detrás de un webinar, quiero decirle, apoyando, generando ideas, conocimiento. Sí, yo creo que es muy importante que lo hagamos. Así que tengan muy buen día a todos y muchísimas gracias por la atención, nuestros colegas de CMU de nuevo, por su apoyo tremendo para este webinar, a nuestros colegas en los países. Así que sin más preámbulo, a nuestros intérpretes que hacen un trabajo fabuloso tratando de entender lo que cada uno de nosotros tratamos de decir. Así que para que mantengamos los lenguajes de cada uno de los lugares y la gente se sienta cómoda, en fin, van a tener los mensajes en Heart. Recuerden, Heart en las Américas, Hearts in the America, website, ¿no? Ahí tenemos todo el material que estamos poniendo a disposición. Gracias a nuestros excelentes presentadores por su cortesía, por su gentileza, por su apoyo, y a todos que tengan muy buen día y hasta la próxima. Sí, saludo a la audiencia de Heart, ¿no? Y nos veremos en un próximo webinar. Muchísimas